Good afternoon, everyone. Thank you for joining us again for Breathing is Living. It's just a little conversation we like to have with people that can contribute to the lung health here in our city. Today, we have an extremely special guest, Dr. Rehman from Desert Radiology. Thank you for joining us today, Dr. Rehman.
Thank you for having me. My pleasure.
So, how did you get connected to imaging?
Yeah, so when I went to medical school, I was really fascinated by imaging and how imaging has, evolved over a period of time and made our diagnosis so much clearer and easier. And also how imaging can be utilized to perform procedures in a very minimally invasive way to treat our patients. So that really fascinated me, the technology behind it and how we utilize that to make an impact in patients' diagnosis as well as treatment options.
Yeah, you know what? It's funny. Some things you never think about. Like as a patient, I would have never even thought about such things. But it is a direct path, technically, right, to what's going on inside someone's body.
Yeah, and be able to see that very precisely and accurately and make a differential diagnosis based on that, it's pretty remarkable. And technology has helped us to get where we are right now in terms of imaging and how we utilize that in our day-to-day medicine.
Mhm.
It's pretty remarkable to me how we are able to make a difference using technology and imaging to help our patients.
So how long have you been just in the imaging side of it?
So I did training in radiology for about 7 years. And then I have been a radiologist for about almost 2 years with Desert Radiology. So ballpark 9 to 10 years.
Wow, interesting. So interesting enough. So where were you? Did you go to school here in Nevada?
No, interestingly, I went to medical school in Pakistan. That's where I'm originally from. So I went to Aga Khan Medical School in Pakistan and
Wow.
to United States, and I trained in radiology up in Connecticut at Hartford Hospital,
Uh-huh.
or going into to Northern California for my fellowship at Stanford.
Oh, wow. So you've been around is what you're telling me. Wow, Pakistan, really? Were you a doctor in Pakistan or did you just decide to go to medical school
So
late?
yeah, I just decided to go to medical school there. Since I was from there and medical schooling was great, so I decided to go to medical school and then decided to come to US for training. And
Oh, that is actually really interesting. That's fascinating. So here you are now in Las Vegas, Nevada at Desert Radiology. Now, are you at Centennial Hills, the hospital at Centennial Hills?
yeah, so we work in collaboration with the Valley Health System, and
Okay.
I'm involved in specifically the lung ablation service that we started at Centennial Hills Hospital. Correct.
Okay. So actually, that's probably the main reason why I wanted to talk to you. And I feel bad, but let me preface this by saying I don't even know what ablation means. I'm just going to be perfectly honest. So you sent me this information, and I actually talked to Corey as well. It's really, really interesting, but it is so far above and beyond me. I'm hoping you'll help me break it down. Okay. So lung thermal ablation program. What does that mean?
So basically, what it entails is we are coming up with new methods to treat lung cancer and cancers in general. And technology has played a huge part in us achieving where we are. And the lung thermal ablation program is basically it employs, CT imaging guidance. We use CT scanner to place small needles about 2 millimeter in diameter, exactly in or around the tumor, and we visualize where our needles are growing, and we precisely and accurately target the tumor. And once those needles are placed in or around the tumor, these needle electrodes are connected to a generator device, and we use that generator device to either use heating or cooling mechanism to destroy the tumor. If we use cooling mechanism, it's called cryoablation, in which we form an ice ball around the tumor. Or if we use heating mechanism, it employs either using radio frequency ablation, which use oscillating currents to generate energy, or microwave ablation, which basically use microwaves to kill tumor cells.
How do you decide which one of those two you're going to do? Is it dependent on the tumor?
So there are a number of factors which come into play deciding what kind of energy to use. In lungs, generally, we prefer using cryoablation in our practice. And the beauty about that is we are able to see the ice ball in real time in the CT scanner. And we make sure that ice ball encompasses the tumor and a little bit of healthy lung tissue around the tumor in order to get the tumor margins.
Mm-hmm.
We also use microwave and radiofrequency ablation. Basically, for lungs, cryoablation works the best, but in other body tumors such as liver, microwave ablation works best. So it really depends on the kind of tissue and what we are targeting. And also then there are other factors that if the lung tumor is close to the chest wall or the pleura, we would use cryoablation since it's a little and it's also pain-free because the ice itself has that effect on the nerves that it causes anesthesia in itself. So yeah, so these are
Okay. So, okay. I'm going to ask again because I want to make sure I'm understanding. So you can target the cell with the needles
right.
using real-time imaging, correct? So is it an X-ray? No, it's a scan.
It's a CT
Is that an X-ray?
Yeah, so CT scan is basically, it employs X-rays used in 360 dimensions to create an image in 3D. And I can illustrate that with an example as well, with an imaging example, if you want to go ahead and share.
Oh, yeah, absolutely. There we go.
Perfect. So the image on our left is a CT scan through the lungs in a patient with a lung nodule that we can see. And that lung nodule basically was biopsy and proven to be non-small cell lung cancer, stage 1 disease. And the image on the right demonstrates how we place these needles under CT guidance exactly and accurately within or around the tumor. And there are two of these needles basically that picked up the tumor like a chopstick basically. And once we fixate these needles, we use the generator device to form an ice ball around this tumor, which is called cryoablation. And as you can see, there are these margins of somewhat ground glass opacities around the tumor, which is the ice ball forming around the tumor. That's how we have ablated the tumor, and also a little bit of healthy lung tissue around the tumor. So this utilization of imaging and the help of imaging helps us to be exactly where we want to be, and also avoid any structures that we do not want to ablate. So the imaging is very helpful in utilizing this technology to accurately treat the tumor cells.
Okay, so I've always pictured a CT scan as a tight tube. I'm assuming this is different. Otherwise, how do you get in there surgically?
Yeah, so it's definitely a tube. Absolutely right, Sherry. It's not that tight. The patient fits in very accurate, easily. And also, once I'm placing the needles, I usually place them when the patient is slightly out of the tube. So I stand right adjacent to the tube, and then I slide the patient in a little bit, see where my needles are, pull back the patient. So I'm able to maneuver the needles, sliding the patient in and out of the scanner in real time.
Oh, wow, that's fascinating, actually. I mean, it's interesting how it's great how everything moves together. I'm assuming also this technology is constantly evolving, correct?
Certainly it does. It does. There are a lot of research and clinical trials out there which evaluates the effectiveness of this technology in different tumor cells. And we are obviously following a large amount of data, how these patients respond in terms of disease-free progression, and also the survival benefits and whatnot. And based on those results, it's basically determined that what technology favors what tumors, and how we can refine this technology or make it better to target the tumor cells even better. For an example, the microwave ablation technique didn't even exist 10 years out from now. So a lot of this is kind of new, and it's up and coming, and it's being utilized by more and more centers in the country.
Okay, I have two questions off the top of my head, and I guarantee you I'll have more in a moment. Number one is, can patients undergo this procedure more than once if necessary?
Yeah, that's a great question. And the answer is yes, the patients can undergo repeat treatments if they have either multifocal disease, which means there's disease in other parts of the lung, we can target that, or even if they have any residual or recurrent disease, meaning that if you treated a tumor and there's a tumor recurrence in that area that you treated, we can again safely go in again and do a quick treatment and come out. So that's a possibility. And one of the major advantages that I see of this treatment is easy repeatability, because the treatment is very targeted and focal, and it does not destroy any lung tissue or healthy lung tissue. So we are able to preserve the lung functions. That's one of the major advantages, as opposed to a surgery, which takes out a part of the lung where the tumor is. So that
Yeah.
compromises the lung functions. And these lung cancer patients are very complex patients because they already have a lot of cardiovascular as well as compromised lung functions because of underlying emphysema. So
Mhm.
for them to undergo a big operation, it can be challenging. So that's one of the advantages of lung ablation, that it preserves the lung function in patients who already have compromised lung function.
Okay. So my other question I was going to ask, and I'm like, I realize this is probably showing my ignorance, but so you go in and you can freeze or microwave, for lack of a better term, the tumor. When you freeze it, is the idea for it to disintegrate? Is that the concept behind this, or do you go in and have to actually remove it then?
That's a very good question, Sherry, and a lot of patients ask this actually. So what happens is, once we ablate the tumor or destroy the tumor using heating or cooling mechanism, the tumor breakdown products are taken up by the inflammatory or immune cells in our body and
Uh-huh.
expressed out of the body. And because of this pathophysiology, major centers in the country are, doing clinical trials on developing drugs which enhance the immune system. So there are drugs being developed which specifically target the tumor breakdown products. So this ablation can work very well with the immunotherapy, and those immune drugs are coming into play now. Checkpoint inhibitors and multiple other immune drugs which potentiate the destruction of the tumor even further with ablation.
Okay. So now, next question. Sorry, I'm just going to throw them at you. Fair enough. Who is the ideal candidate for this? Obviously, it's not everybody with every type of lung cancer, or is it? Can it be anybody?
Yeah, so it's a specific type of lung cancer, which is non-small cell lung cancer. If we broadly divide the lung cancer, it's non-small cell and small cell.
Mhm.
Small cell are relatively faster growing tumors for which this treatment is not effective, but it's the non-small cell lung cancer for which these treatments are effective. So we do a biopsy at first to determine what kind of cancer it is. And then it also depends on the staging of the patient. And as I described, the patient's lung functions and their cardiovascular comorbids. So not one treatment fits all. And lung cancer is a very complicated problem. So we determine based on a particular patient and in consultation with our medical and radiation oncologist and our pulmonologist that this treatment may be the best for this patient. So generally we treat tumors which are about 3 centimeter or less in size, and they have shown to have great outcomes in clinical trials. And also we are able to treat, as we discussed earlier, multifocal disease, which means if there are tumors, 2 or more tumors in one lung, we can treat that effectively, because in those cases, surgery is not a great option, because how much longer are you going to take out with
Yeah.
compromised lung functions? So multifocal disease and patients who have a lot of emphysema, patients who can't undergo surgery, and in patients who want to preserve the lung functions, I think this is a great treatment option.
Interesting. So there's not necessarily like an age cap, like you can't do it in someone over 50. It depends mostly on their physical health outside of the cancer, correct?
Absolutely. And this is, again, a very minimally invasive and a quick recovery time. Most of our patients go home the very next day after the procedure.
Wow.
Very minimal complications, if any. So it's a fairly safe procedure. And I'm able to offer this to any patient who basically can walk into my clinic on their own and go out, basically, who are in a relatively decent health. So yeah.
So it doesn't matter what stage your cancer is either then, correct?
Yeah, so basically we treat stage one tumor when the tumor is less than 3 centimeter in size.
Okay. That's right. You said that. I apologize.
No, absolutely. And
I
there is,
got excited.
and reasonably so. And they do not have a lymph node, positive lymph node. So the
Okay.
tumor is less than 3 centimeter in size and no positive lymph node. That's one indication. And the second indication is also if they have a tumor in other parts of the body, like a colon or renal cancer with metastatic disease to the lungs. So the lung cancer is not the primary lung cancer, but it's a
Mhm.
cancer from other parts of the body. So we can also treat that metastatic disease if they are less than 3 in number in one lung or less than 6 in number in both lungs combined.
Mhm. Would you say that this procedure is gaining in, I hate the word popularity, but that's the word I'm going to use in this particular instance, because I imagine that people are slow to hear about such things. Sometimes, the information doesn't trickle down as quickly, which is why I wanted to do this. Do you think it's gaining in popularity, or is there a ton of room still left?
No, I agree with you. It's certainly gaining in popularity. All the major centers in the country are doing it in some shape or
Okay, good.
East Coast and the West Coast, and I'm glad now we have this service available to our Southern Nevada community as well. So it's definitely gaining attention, and also medicine is evolving as we discussed with technology, and this is such a minimally invasive way. As we saw an image, we place a needle accurately within the tumor, and we are able to destroy the tumor, come out, patient go home the next day without having a big incision or scar or surgery. So definitely it's up and coming, and with in conjunction with now immune drugs being developed and available, I think this is definitely what the future holds for us.
So do you think though that it's a good idea for people to at least ask their doctor if they're a good candidate for this?
Absolutely, absolutely, and we have been trying to get this word of mouth around that this is available, and I've been talking to a lot of pulmonologists and oncologists in town, and making them aware that we offer this service, and it may be a great option to treat patients who may not be great fit for surgery to begin with. So definitely, I think I encourage patients to ask their healthcare providers about this treatment and if they are a good candidate for it.
Hmm. But good to know, stage one, 3 centimeters, 3 millimeters or centimeters. Okay, or less. And then,
And metastatic disease as well, if they have cancer in other part of the body and it has gone to the lung, so we can.
right. So I'm probably going back, but this is sometimes how my mind works. Um, in that you can do it more than once. Has it ever happened, or is it possible or feasible that you've treated a tumor, and let's say 90% of it disintegrated or did what it was supposed to do, but there's a little tiny bit still hanging on? Can you go back in and do it again to that same tumor?
We certainly can. We certainly,
Awesome.
that's one of the major advantages of this, and there have been cases reported. It doesn't happen quite often, but as we know, tumors can behave in different ways. So if a little bit of tumor is left, and we follow, once we do these procedures, we follow our patients with serial imaging every 3 months for the first year. So we get a CT scan and then a PET scan, and that tells us if the PET scan is lighting up, that there is tumor left behind, or what's going on. And based on those imaging, we certainly can go back in again and freeze that tumor again. So it's a very easily doable procedure in terms of repeatability.
Oh, it's so interesting to me. I love that the advances keep coming and coming. It's difficult though, like you said, to get the word out. So, because I've had a friend that just had a stage one lung cancer, and she had the surgery and they removed part of her lung. Might have been the right choice for her. So I'm not a doctor, but it's just really interesting to know what's available. So do you know of, or do you feel that this will expand into other cancers?
Yeah, certainly. And, this has been employed in liver as well as kidney cancers. And that has been even longer for the lung cancer, to be honest. So we do it for liver cancer. We do it for renal cancers. We also do it for some bone cancers, like osteosarcomas. So it has a lot of applications in cancers in all the parts of the body, pretty much from neck down to the feet.
Wow, that's interesting. Does Desert Radiology do all of those cancers too then?
We certainly do. We provide imaging services for liver, kidney, as well as the bone cancers. And we're also, starting our program on thyroid, goiters, ablation.
Mm. Tell me, this is a dumb question. I'm going to ask it. Tell me what the word ablation actually means.
So ablation, basically, it means that, destroying the tissue. So
Thank you.
we're destroying the tissue using energy.
Okay.
And use at either extremes, so heating energy or a cooling energy. And in lung particularly, we employ cooling energy, as I said, so it's forming an ice ball. And just to kind of give you an idea, the temperature of that ice ball at the core is minus 160 degrees centigrade. And at the periphery, it's about 0 degrees. So at that temperature, no cells in the body can survive.
Yeah.
So that temperature destroys the cells. So that's ablation for you.
Mm.
So once those cells are destroyed, they're picked up by the immune cells in the body and excreted out of the body. So that's what ablation constitutes at a cellular level.
Gosh, that's a miracle. Literally, you know what I mean? It's a miracle. This is why I have to appreciate medicine, and it's why I tell people I'm not a doctor. This is so far beyond my ability. So,
that's one of the reasons that really attracted me into imaging and radiology. What we are able to, when we are able to utilize technology to do such great things, both in terms of diagnosis as well as the treatment option.
So I'm going to ask you a researched question necessarily. It's just curious. So if you don't have the answer, I'm not going to hold you to anything, but I'm curious if you have seen in your 2 years here, correct? Have you been here 2 years? Okay. In your 2 years here, have you seen an increase in lung cancer?
So I think so. I mean, it's kind of hard to evaluate just on a very small data, but there are data being published out by the United States Preventive Task Force. And that basically, their most recent report tells us that the people who qualify for lung cancer screening between the age group of 50 and 80 is 12%. So 12% of all individuals in the country between the age of 50 and 80 qualify for lung cancer screening. And that's based on your history of 20-pack year of smoking, and currently smoking, or if you have quit in last 15 years. And you wouldn't believe it, it's kind of unfortunate that only 4% of the people who qualify utilize this lung cancer screening. So there's a huge gap that we have to bridge in terms of pushing the patients for lung cancer screening. And that's one of the things as part of Desert Radiology we are trying to do to make more awareness for lung cancer screening, because as we discussed in our session, that if we pick up cancer at an early stage, there are so many treatment options available which can be curative.
Yes, that's actually, it's interesting. I was just gonna, in my mind, that was my first thought was, one of the reasons why people don't want to get screened is they're afraid they're going to have cancer and they're going to find out. But if you find out early, then we freeze it, destroy it. I mean, it's not 100% every time, and I totally understand that. But if you get screened early.
So that's the thing, if you pick up a cancer at stage 3 and 4, you're limited with options, right? You cannot eradicate in totality. So then you're looking at chemotherapeutic agents or medical oncology to kind of control or limit the spread of the tumor. But you can't eradicate, or these patients can't move, move past their tumor. So it's kind of unfortunate. But that's why screening is a huge thing in cancer management in general, and specifically in lung cancer, because there's as you said, a lot of people are reluctant or do not have that knowledge to get the lung cancer screening if they qualify for it.
So again, not to put you on the spot, but I'm just curious. Working for the American Lung Association, I know 50 is the age. That's the age that insurance covers it.
Correct.
Right, your screening. Is that what we find? Are we finding that people over 50 are nearly the only people getting lung cancer, or do you see it popping up earlier and earlier in age?
Yeah, so that's a great question, Sherry. And I just want to kind of emphasize the importance of that question by saying that there is a United States Preventive Task Force that set these guidelines for patients who qualify. And believe it or not, the guidelines became stricter last year. Uh, they were 55 to 80, and they have pulled it back to 50. And for smoking history as well, it was 30 pack year, it's down to 20 pack year. So we are seeing, as you correctly pointed out, lung cancers in younger and younger age groups, and that's why the criteria are becoming even stricter. And all these criteria are driven on large data and clinical research.
Mm.
Definitely, if you have a long history, you are very likely, or to get lung cancer. So then comes the role of screening at an early stage. But for now, 50 to 80, and if you have a 20-year past history of smoking, you can be a candidate for lung cancer screening. And if you pick it up early stage, we can absolutely treat it.
Right. And here's just one treatment that you can do in early stage that's like not as traumatic, let's just say, which I think is amazing. So again, we're back to reminding people, though, they have to advocate for themselves. Not that their doctor doesn't care, their doctor does care, but I imagine it's hard to keep track of everything for these people. So would a doctor send them to you and you would help them decide whether they were a candidate for this particular procedure?
Yeah, generally that's what happens. A lot of our patients come through because cancer is such a complex problem to deal. A lot of decisions are being made in multidisciplinary conferences. We do tumor boards with some of the big groups in Las Vegas, and by talking to medical oncologists and radiation oncologists and the pulmonologists, we decide what may be the best option for this patient, and that's how we get patients for lung ablation. But definitely we are trying to reach out to more primary care providers and pulmonologists to educate them about this procedure, and at least send us a referral to see if we can evaluate those patients by ourselves, and also in conjunction with our partners in oncology to see if this is the best treatment option for them.
Just out of curiosity, how long typically does it take for a patient to get in to see you for this particular procedure? Is it like a 3-month waiting list, or is it shorter than that?
No, not at all. Once I have a referral, and I usually try to schedule my patients within a week to 10 days, because as we discussed, time is money, especially in lung cancer. Once the cancers can spread really fast, so 3 months is a very long time, and the stage of the cancer can be advanced certainly in that time span. So I try to schedule my patients within a week of when they're referred to me, and try to get them to biopsy first, and make them get them cleared from a cardiovascular standpoint for this procedure.
Okay, and I'm gonna. This is also a silly question, but what does the initial screening look like? Is that a CT scan? What is that scan?
Yeah, so it's a low dose CT scan. So the amount of radiation that we use in a normal diagnostic CT scan, it's less than that. So it's a low dose CT scan, in which we look at the lung nodules basically. So if there is any nodule in the lung, 1 millimeter, 2 millimeter, we pick that up, and we follow them with a serial every year CT scan. And if the nodules reach a size of about 6 to 8 millimeters, then we get CT scan in 6 months. And if the nodule is greater than 8 millimeters, then a 3-month follow-up is recommended. So there are guidelines based on that low dose CT scan in terms of evaluating the nodules. So it's a low dose nodule, and I also want to kind of use your platform to emphasize that a lot of patients get worried about the radiation in low dose CT scan and getting that every year. So the amount of radiation that a low dose CT scan offers, it's almost similar to 6 months of natural background radiation. So if you're not doing anything, just the natural background radiation of 6 months equals to one low dose CT scanner. So it's not that much at all.
Mm-mm.
And given how much impact it can make by diagnosing a cancer early stage and having it cured, as opposed to being in an advanced stage and not being able to do much.
Mm-hmm. So you said something that made me think about this question. Are not all nodules are cancerous, correct?
That is correct.
Would you, would it be advantageous to do this procedure for non-cancer nodules, or would it not make a difference?
No, it won't make a difference because if they're not cancers, they're not growing. So generally, there are certain indicators for a nodule to be suspicious based on the imaging, and one of that is growing. As we all know about cancer, one thing about cancer, it likes to grow. So
Mhm.
it's growing and it has certain morphologic characteristic features. It has solid and ground glass component, and that's more of clinical minutia I'm talking about. So based on those factors, we determine that a nodule may be suspicious, and then we further work that out with a PET scan, in which we give glucose, and that's taken up by any cancer cells in the body. And if that's correct, then we proceed with a biopsy to make sure that it's cancer and what kind of cancer it is, and then we decide on ablation or any other form of treatment option.
Wow. Look at that. I mean, it gets deeper and deeper. But it's worth keeping track of, right? I mean,
Right. The more information we spread, the better it is, and as we talked about, the first step really in getting into all of this is making sure you get lung cancer screening if you qualify for it. It's only 4% of our population that qualifies, so we still have those 96% of the people not going in, and that's the reason lung cancer is the number one cause of cancer-related deaths,
mhm,
and it causes about 2 million deaths worldwide every year, and
mm,
ballpark 200,000 deaths just in United States every year.
mm.
So huge problem, and I think once we spread the word of mouth and educate more people about it, and they are more prone to getting screened, we can help lower the numbers certainly.
Yes. So let me ask you this. Um, what I have learned in this job is that no, you don't have to be a smoker to get lung cancer, right?
That is absolutely correct. So certain tumors are the tumor. Basically, there are a multitude of risk factors because of which tumor can develop. Cigarette smoking plays a huge role in lung cancer, particularly.
Hmm.
There are also genetic factors, and exposure to other forms of radiation, and so many other things that can also trigger lung cancer. So it's not really cigarette smoking, but majority of our patients have history of cigarette smoking, and every now and then we get one person who have had a family history of multiple other cancers and
Hmm.
fortunate and develop lung cancer.
But also, I want to bring up secondhand smoke, especially in this town where you're a server or you're working in a casino and you're surrounded by people that smoke. That's cigarette smoking, is it not?
No, certainly. I mean, that also has its risk factors. Certainly, obviously, the amount of carcinogens, basically the components that causes cancers in the cigarette, are not as much in cigarettes, secondhand
Right.
smoking. But then again, it's not only about cancer; it also causes other disease processes like bronchitis,
Yeah.
or overall health of your lungs are compromised by inhaling those harmful chemicals in secondhand smoke as well.
Hmm.
So then it's over a period of time. Once you have damage to the lung and it tries to repair, and once the repair mechanism go haywire, that's when a cancer develops. So obviously their chances are also increased, but certainly not as high as first-hand smoke.
Also, but one of the things that I was thinking about was that yeah, it's easy for me. I don't smoke and I don't hang out in, I'm not a server. I don't hang out in casinos, but I still think maybe at some point I should probably have one screening for lung cancer at some point in my life. Would you say yes or no to that?
So I would strictly go by the criteria. If you have had a history of 20 pack year smoking and you've
Okay.
fallen, I would definitely recommend you should. But if you do not technically qualify for the lung cancer screening per se.
Right.
Have respiratory symptoms like shortness of breath or any chest pain or any cough, you can get a diagnostic CT, and that can equally tell us if you have any lung nodules or if it needs to be followed.
That
Uh,
was it. That was it. I knew there was something that somebody had mentioned to me. It's, like a chronic shortness of breath, correct? Like not just because I just walked up the steps.
we all get short of breath, climbing a flight. Chronic shortness of breath, or if it's persistent and a long term, and along with that you have any productive cough or any other symptoms, you should definitely get checked out for that.
So interesting though, if I'm not mistaken, we have just now described the COVID-19 symptoms. It's hard to tell the difference at this point.
I know. We're living in a different world altogether in the last 3 years. So there's a lot of COVID-related complications, and we are seeing long-term COVID complications as well. A lot of our patients who have had COVID a year or two ago are also having complaints of prolonged shortness of breath. And when we do CT scans, we see characteristic findings of COVID. So yeah, it's kind of COVID is basically really masking up a lot of other medical problems that exist.
Mm-hmm. Wow. So just be aware, really, is what all we can do. Just be aware of how you're feeling, evaluate your breathing. Are you at risk? Have you been smoking for a long time? Did you quit within the last 20 years? Is that what you said? Or you smoked for 20 years?
Smoke for 20 years and
Okay.
a smoker, or quit within the last 15 years. But even if
Okay.
you within the last 15 years, you do qualify for lung cancer screening.
Okay. Wow. Well, okay, so there we are. Tell me what I've missed. Have I missed anything? I feel I've been pretty thorough, but
No, I think we covered all the salient points, and I just want to kind of reiterate and emphasize that lung cancer ablation is a great tool. It's minimally invasive, a very short recovery of 1 day, and it's as you pointed out, it's very repeatable easily, and we can make a lot of difference in patients' lives, especially candidates who are inoperable because of their cardiovascular and limited lung capacity. And yeah, so please do contact us if you think you may qualify for consultation, and we're here to help you out.
I love it. I love that you suggested this. You are right. This is something we all needed to hear. I cannot tell you how much we appreciate you talking to us today, Dr. Rehman.
My pleasure, Sherry.
Thank you.